Hi, I'm Dr. Derek Lee. I'd like to introduce Dr. Tony Herring, who is Chief of Staff Emeritus at Texas Scottish Rite Hospital in Dallas, Texas. Dr. Herring is the recipient of the 2018 SRS Lifetime Achievement Award for distinguished service to the society, as well as distinguished contributions to spinal deformity care. Dr. Herring is on numerous societies and boards, which I don't have enough time to mention, but he's also on the editorial boards of the Journal Spine, the Journal of Pediatric Orthopedics, and a reviewer at the Journal of Bone and Joint Surgery. Dr. Herring, I know you have about 40 plus years of career in terms of orthopedics, and you were board certified in 1974, and it seems that your forte is focused a lot on research, and you've looked at new procedures, research overall over time. I was wondering if I could touch today on your expertise in fusion and your perspective on tethering as well. Overall, what's your perspective on vertebral body tethering?
Well, maybe we'll back up a little bit. The first instrumentation for scoliosis was by Harrington. And he very much wanted to not have to fuse the spine. But the problems came in that when you have motion in the bone and the hooks and various things up against the bone will react and eventually things will come loose. And likewise, rods and things, if there's no fusion underneath and there's motion, sometimes it's like bending a paper clip. You bend it over and over and over again and it will finally break. And so it's called fatigue failure. Maybe you do 1,000,000 cycles, but it will eventually break. So he ended up then converting his procedure to one in which everybody got fused, except really young kids who were growing. Then instrumentation has come a long, long way from then, so that now the fusion instrumentation is very strong. We get excellent correction, and we can get it safely by monitoring the spinal cord. And so the fusion is sort of the gold standard for most idiopathic scoliosis kids. Lately, in the last few years, the idea of tethering has come along. And the idea is that if you put connections in the vertebra and connect them to one another with a cord, that the spine, while it's growing, will gradually straighten and will then remain straight once you finish that. Dr. Newton and others have really proven that the concept works. They've shown that the spine will correct and grow and correct. I have not been doing fusions or tethering for the last 5 years because I'm reaching really retirement age. But I've kept up with what's going on, and I was asked to review Dr. Newton's papers. Blinded, I didn't know whose papers they were when I reviewed them, but the problems I saw there were primarily around not having enough experience with it to know what's going to happen down the line. All of the early stuff shows certain things, but it shows certain problems because a number of times the cord connecting the screws together will break. And that's pretty predictable. You would hope it would take many years to break, but they're showing really a fairly frequent breakage in the shorter series over just a few years. So the question comes up, well, what happens if it breaks? And is the curve going to keep getting worse? Is the motion going to be distorted in the spine? And are there some negative consequences of that? And there have been cases where they've had to go back and do a posterior fusion after the tether is broken in front. So my plea in the things I've written about it has been to not just go ahead and start doing it everywhere in the country. Work with a few people who are doing really good research, like Dr. Newton and others, and give them time to work out some of the problems. We don't know what's the best age. They really don't know that. If you do it too young, they overcorrect. If you do it too late, you don't get much correction. And so lots of questions come up that really need to be answered before it just becomes something that everybody starts doing, because we'd like to know some of the problems ahead of time.
Oh, for sure. that is the case in terms of with new procedures. In the
Sure,
history,
always.
so with the history of new procedures, right? Because the history of medicine is almost taking leaps of faith sometimes without even enough of the like Dr. Newton's work in terms of animal research and et cetera. There's a fine line between pushing and just gathering enough research as well, correct?
Right. Right, and there's a fine line between doing cases, following them very carefully, making modifications and studying what you've done and publishing it, versus just doing cases over and over again and not really looking at it from any sort of a scientific evaluation. That's, I think, my emphasis would be on not everybody doing it quite yet, but those doing it, study it well, make the necessary modifications, find better tethers that don't break, and then let it be more widespread, because enough problem has shown up already that you just don't want to have hundreds and hundreds of kids with problems that you don't quite know how to solve.
Right. Now with Dr. Samdani and his work with the FDA and with approval last summer, does that impact your perspective at all?
Well, the FDA is approving a device.
Okay.
And if it's been used in other situations, it can be approved, even though there's not a lot of experience in a new situation. So FDA approval is important, but the clinical follow-up and publishing results of a number of patients with all the different aspects that come along is really much more important to understand the usefulness and the limitations of a new treatment. I'm all for new treatments. I love innovation, but it needs to be done with good reporting and good follow-up and necessary modifications as they come along.
I understand. Well, it seems that there is a cluster of very experienced tethering surgeons who are trying to gather data in groups. They seem to be cooperating.
Right.
You know, Dr. Newton, Dr. Samdani, Dr. Angie, Dr. Perron.
Right.
What is a typical timeline in terms of proof of concept enough in terms of rolling it out to more surgeons as a standard procedure?
Well, let's say you see that 40% of the tethers are breaking in a 2 to 4 year follow-up. I think that tells you that you better watch out a little bit, and you better get some 5 and 10 year follow-up, because it's, you know, they're not, it's not certain, or nobody really knows what's going to happen. This has never been done to the spine before, so what's the reaction? And hopefully it's no big deal, but you got to have some experience to answer those questions.
Well, absolutely, because that's how the data speaks for itself, right?
Right.
With, for instance, Dr. Peter Newton and his published work, and he's the one who, of course, introduced you to me to get a different perspective, right?
Right.
Have you talked to him much in terms of after he published that research?
We've talked some, yeah, and he's a very good friend of mine. I trained him. He was one of my fellows. And,
okay.
So we're very good friends. He's one of the most talented people in the field, really, and extraordinarily good surgeon, good researcher, very, very capable. And you can believe his publications. I mean, what he says is the truth. And so we haven't really had any arguments about it. As I said, when I actually was reviewing the papers about it, I didn't know that he had written them. I just was sent them by the journal, as you know, as they do. It's all blinded, which is good. So you just give your basic opinion. But I was disturbed by the, you know, his paper compared the posterior fusions, most recent paper, the posterior fusions with the tethering. And there was quite a list of issues with the tethering, but there were no issues with the posterior fusions. So at this point, you still look at that and you say, you know, I think right now, my daughter, I would still do the posterior fusion if you're only doing the thoracic curve, because it's just so well known. I mean, there are some problems, but you know, we've worked on that for 20 years and have solved a lot of the problems. So I think it says there's work to be done, and I think he knows there's work to be done, and I think he's one of the many people who will do really good work on it. So I'm not in any way against people doing it. I am against doing it without really studying it and improving it.
You're right, and keeping it to the surgeons who are able to publish the research competently.
Right, right.
Okay. So when
let's know more about it before everybody starts doing it.
So when Dr. Newton talks to you about the tethering and how he sees it and his history with it, you guys get into discussions about, and he agrees with you, of course, in terms of it needs to be more research before it expands to other practitioners?
No, I think we're in agreement. I haven't had any arguments with him. I think we see it through the same light.
If we can move over to fusion.
Yes.
Okay, which is your specialty, of course. You know, parents always worry that if you're fusing a specific area, the thoracic spine, not as much because there's limited flexibility there when you compare it with lumbar, correct?
Right.
And when you fuse certain areas, the areas above and below tend to pick up the slack in terms of increased movement to compensate. And oftentimes that can lead to degenerative disc disease, degeneration in general, which is one of the problems that can possibly occur. Has that really been solved in terms of over the 20 years of fusion?
Well, and actually there's some very good papers looking at the long terms of fusion. Some of them are out of Scandinavia, Sweden especially, where they looked at people that had 30 and 40-year follow-up after fusions. And if you're just looking at the thoracic spine, the thoracic curves, mm-hmm. The long-term implications are not negative. You know, patients do very, very well. And mm-hmm. as you mentioned, there's not a lot of movement in that part of your spine, and you make up for it for movement above and below. But it doesn't seem to be causing degeneration on the ends of the fusion. Mm-hmm. The further you get down in the lumbar spine, the more you get noticeable loss of motion. And if you get down to L3, it's not too bad. Get down to L4 or L5, you lose a lot of motion. And I think the lower down you have to go and the more curve that you leave, the more likely you are to have degenerative problems at the end of the fusion. Mm-hmm. The fusion area itself, you know, occasionally doesn't fuse solidly, but if it does, then that area is fairly inert and not causing much problem. But you definitely get issues as you limit more and more motion, you get more and more issues. And so you'd much prefer not to do that. If you could get the tethering or other non-fusion techniques mm-hmm. to hold up, you're fighting a basic issue in that goes all the way back, as I mentioned, to Harrington in the first fusion with rods, is that motion of any kind of implant in the body against bone tends to loosen or break. And it's true of total joint replacements. It's true of spine implants. So it's kind of a basic principle that's gonna give you issues one way or another. So you've got to figure out how to conquer most of the issues before you mm-hmm. can do straightening without fusion.
Yes, everything's going to fatigue over and fail over time.
Yeah, and you know, people live a long time. You're talking about dealing with teenagers, so they got a long lifespan, and you'd like to know a little more about it.
Now, can I ask you, when it comes to fusion, is there a standard time to do fusion for an adolescent, or does it just depend on the progression of the curve? So, for instance, if you're closer to less bone growth, do you kind of try and wait as long as possible, or it's the severity and progression rates that?
Well, you want to do the fusion when when you need to do it. So when the curve gets to a certain magnitude, you know it's going to go ahead and get a whole lot worse. So if the person that is between 11 and 20 years of age, whenever you see the curve reach that spot, you want to do it then. You don't want to let it get really bad, because then you don't get as much correction. You have more danger with doing the surgery. Where we get into problems is younger kids also develop scoliosis. So you can see 8-year-olds and 5-year-olds and even 18-month-olds. Well, you can't fuse them. They've got to grow. And so those are really challenging situations. And a lot of people have done really good work with them, as our institution has done as well. And lots of techniques have come along that tend to get better and better over the years. But because you're instrumenting and you're not fusing, things break, things come loose. So you've got to have a plan of fixing things when they don't hold up. And then as the child gets later in their growth, to say 10 or 11, you can go ahead then and do the fusion. So within the sort of mid to late adolescence, it's time to do it when the curve has gotten bad enough that they're going to have problems with it increasing throughout their life. If it's not so bad, 30, 40 degree curve, they'll stabilize a lot of times at the end of adolescence and not need fusion. And we do lots of bracing to try to avoid fusion. Bracing is very effective up to a certain degree, but after curve gets to a certain level, then the bracing doesn't work.
Well, since we're on bracing, I noticed that you did a little bit of a review on scoliosis-specific exercises and whether or not they actually have any impact on curve progression.
Right.
Yeah, I stalked you a little bit, Dr. Herring, and it was interesting because you didn't really, the review indicated that there wasn't much impact. Was that with bracing at the same time, or was that just specifically with scoliosis-specific exercises?
Well, what we did was review the literature. One person at our institution does the Schroth method, and I spent a lot of time talking with her too and seeing how her patients were doing. But the literature is too mixed to be valid, really. The problem is, let me go back one step. We did a big study of where we monitored the amount of time the patient was wearing the brace by heat, by when it was hot. And so when the brace is on, they're wearing it. When it's off, they're not wearing it. And we compared that with the opinion of the surgeon, the opinion of the therapist, the opinion of the mother and the child, and of the orthotist. And we found that you couldn't believe anybody. Even the surgeons or the orthotists, you only knew how much they were wearing it by looking at the monitor, because the other information was worthless. They'd say they're wearing it all the time, they weren't wearing it at all. And you didn't know that. So if you look at these studies that look at the Schroth or the exercise methods versus the brace, most of the time they mixed them together, and most of the time they couldn't look at how compliant the patient was with the brace. Did they wear it at all? And they couldn't document how many hours a day the patient did the exercises. So you're really dealing with we gave the patient a bucket of pills and some of them took it and we think it worked pretty well. Well, you don't know. So I'm neither for it or against it, but as I analyzed the things that the people that are doing had published, there was just nothing that was really valid. No, you just couldn't make any conclusions from what was in the literature. And then, you got to validate it somehow, because it's expensive and it's popular, but it's much more popular in Europe probably than in the USA. And but you'd really like to know if there's some data that it really works or not really works. And
yeah, I agree, because I was well, even with my child, in terms of trying to figure out if bracing was effective or what even style of brace to use. There's so many variables. And I also had issues with the braced study in terms of, because up here in Canada, one of the first surgeons I saw was part of the brace study, and in terms of the bracing technique that she particularly used. And there were so many question marks in terms of the type of brace, if it was more of a 3D or a traditional Boston type brace, or if even with respect to the amount of time post-fitting to determine if what the in-brace correction was like. There's so many variables that I was going, is this really a good study or not?
Mm-hmm.
And that seems to be the case with a lot of bracing and scoliosis-specific exercises in general. It's difficult to do.
Yeah.
And track
we can now with really good accuracy tell how much the patient's wanting to brace.
Okay.
But there's still variables. How tight is the brace when they have it on, you know,
Mm-hmm.
and various smaller variables. But we do find there's a good correlation between wearing the brace and controlling the curve up to a certain level. If you start with a great big curve, it doesn't work. But if you start with a moderate curve
Mm-hmm.
and the patient wears the brace, it almost always works. It doesn't always. There'll be kids that are good brace wearers and their curve still increases, and we don't understand that, but that happens as well.
Which is another question I have for you in terms of bracing. Do you find what are the alternatives if the child just can't tolerate a brace? They're just not compliant.
Well, and you know, certainly we see that, and you have a discussion with them, and there are kids who say, you know, I hate the brace. I hate that the people know I have it. I don't want to wear it. I don't like the way it feels. And you try to make it so it's as comfortable as it's possible to do it. You modify the brace and do whatever you need to. But you can just have a discussion with them. Well, we think we'll probably go ahead and need surgery if you don't have the brace. You don't need it now. So we'll follow you along. We'll take care of you no matter what you decide.
Mm-hmm.
But there's really not another treatment method that we could employ right now. So we'll take care of you one way or the other. But you got to understand that if you wore the brace, you'd be much less likely to have the surgery.
Yeah. And
there are kids that say, well, I'm happy to have surgery, and I'll come back and see you every 6 months, and when I need it, let's go ahead and do it. And that's their free will.
Do you feel that with kids in brace, they should also be doing at least some form of exercise in terms of trying to maintain, muscle strength? Because of course you're bracing often 20 plus hours a day. So much muscle atrophy in the trunk. What are your thoughts on that?
In our early years, we did that. We put them on some exercise programs. Mm-hmm. We couldn't really tell whether it made any difference, and we couldn't tell really how much they did it. We certainly encourage them to do athletics and to be in as many sports and as many activities as they can, and that they can do those activities when the brace is off. They don't have to wear the brace for the activity. So we encourage a really active lifestyle, but we don't really put them on a specific exercise program.
Okay. Because just a thought in terms of, it just seems in a rehab setting, or, if you immobilize an area for too long, even with cervical collars from, whiplash.
Sure.
That used to be quite standard protocol that they've since then tried, unless there's significant instability, try not to
right.
prescribe that because of muscle atrophy, right? So
right.
It does seem like a reasonable course of action just to try and stabilize curves a little bit more in brace. Anyway, if I can ask a few more specific questions about fusion. It seems that they do a full discectomy.
What you said there really is not correct.
Oh, okay.
Yeah, for posterior spine instrumentation and fusion for scoliosis, that's the commonest procedure. We do not do anything to the discs. Only for certain kind of more complex situations do we go in the front and fuse the disc. But in the normal scoliosis surgery, the discs are not seen or touched from behind. So they're still intact.
Okay, that's fascinating. I thought it was, so it's immobilization by the pedicle screws and the rods and the lack of movement that causes autofusion.
And the fusion in the back, yeah. But the front is not done. We also, in the past, used to do quite a few anterior instrumentations and fusions. Mm-hmm. And we did take the disc there and we did fusion the front and not fusion the back, but that's not done much anymore. So now the posterior surgeries from the back, we do not really do anything to the discs.
That's interesting because I was misinformed. So the disc will basically auto-fuse over time with lack of movement. Is that how it works?
Mm, I don't know that we know that. You don't see them fused on the x-rays.
Mm-hmm.
It doesn't appear to be fusion across the disc bases on the x-rays as you follow them. Some probably do, but there's not something I could say we expect the disc to fuse. I don't believe we do.
Okay. So in terms of fusion posteriorly then, if the discs are still viable, and how is the fusion actually done in terms of solidifying movement? Because like you said before, if there's still movement, then failure of instrumentation.
Well, the fusion is done across all the elements in the back.
Posterior elements.
Lamina, the transverse processes, the facets are all fused from the back. So that fusion, and it can be, half an inch thick, is bone. We lay bone graft over it. And that is where the solidification of the spine occurs, is by the bone in the back, but not through the discs. The discs really are just kind of passive at this point. There's not motion going through the disc. So they're not really functioning as movement, components.
Yes, they can't, of course. Okay. Now it seems with scoliosis, the current theory, of course, idiopathic adolescent scoliosis, by definition, is we don't know, the cause is not known. But once it starts going, it seems to be that anterior vertebral overgrowth causes wedging of the vertebra, A to P, leading to hypokyphosis and rotation, then scoliotic curve. So when, with respect to fusion, because I've talked to some other fusion surgeons as well, and some of them seem to believe that the derotation of the spine is quite critical, but sometimes they do the disc release in order to reduce the anterior column to allow that to fit a little bit better derotation. Is that incorrect as well, or misinformed?
Some people may do that. That's not a standard sort of procedure.
Okay.
For routine idiopathic scoliosis. It's most of the time you do anterior release surgery with scoliosis surgery when you have a really, really big curves over like 100 degrees, where you have very long-standing, very severe deformity. Okay. We do anterior disc releases and wedging and that sort of thing to try to get correction of a very severe curve, but you don't do it in the average curve.
Now I have a question about balance curves as well. So if you have a significant thoracic, let's say 45, 50 degrees, same thing in the lumbar in the opposite direction. Some surgeons will just say, perhaps that's okay, you're balanced. Others want to basically see if they can correct that with the anticipation that it's just going to get worse over time, even though it's balanced and their head and pelvis are aligned. Any thoughts on that?
Well, it gets difficult when you don't really know. Let's say you have 40-degree balance curves. Thoracic curves 40, lumbar curves 40. We have pretty good data that those will be stable in adulthood if that's where you are when you finish growing. You get up to 50, then a fair number of them will continue to progress. And somewhere in between there, you have to just make a judgment. You think this doesn't look good now and I'm afraid it's going to get worse. Let's go ahead and fuse it. Or the person looks great, they're very active, they're not having a problem with it. They could always have a fusion when they're 25 years old if it does get worse. So not to do it. And it's very much a judgment call in a situation where there's so much individual variation that even though you can study a population of people, you don't really know what that particular patient's going to do. So a lot of it's just kind of judgment and is this the time to do it or is it not? And certainly the patients should be involved in all those decisions. They say, well, this is a good time in my life to do it. If you think it might be necessary, let's go ahead. Or they can say, you know, I've got all this stuff I got to do. I'm going into college. I'm doing this. I don't want to have any surgery right now. Can we wait? And you really incorporate them in these decisions as well, because you don't have a lot of certainty.
In your experience, and if we take a case in terms of a young girl comes in, typically scoliosis with females, and she still has growth remaining. Maybe she's a Sanders 3 or 4. She has a 50-degree curve, which is suspecting that's progressing. How would you handle her case from your point of view?
At a 50-degree curve with that much growth remaining, I would go ahead and recommend a fusion and a correction and fusion, because you'll get really good correction. They'll tolerate the procedure well, and there's no real reason to doubt that it's going to get worse. So you don't really, you say, well, they're still growing, but they have, let's say they have 2 inches of growth in their spine left. When you do the correction, you're going to gain about 2 inches. So as you make them straighter, they're going to be 2 inches taller anyway. And so you're not losing that much growth. Now, if you said it's an 8-year-old, that's all different. But if you have somebody that's in the middle of their adolescent growth spurt, you don't have a ton of growth left. But you have to look at their growth parameters, see what their growth rate's been, see how tall their family members are. And you get an idea of if there's more growth there than you would want to deal with.
I just want to touch back on Dr. Newton's tethering. He does hybrids in terms of trying to spare the lumbar spine, because, of course, fusion of those areas we try to avoid, right?
Right.
And he tends to tether the lumbar, but selectively fusing the thoracic for for long curves or thoracolumbar curves, that type of thing. How do you feel about that particular protocol that he's developed?
Well, I think the rationale is good, and I think he's certainly the person that should be looking at that sort of innovation as well, and should let us know how well it's working and publish it and refine it so that we find out if it's a great idea or has some limitations.
I'm sure you're exposed to, because of your research and your reviewing, that type of thing, and being on editorial boards. What do you see happening in the next 5, 10, 15 years in terms of fusion, non-fusion, any particular kind of corrections for scoliosis in adolescents?
Yeah, that's a very good question, and I answered that with my residents and fellows a lot too. I think there's going to be a gradual move back toward anterior surgery and away from posterior straight across fusion surgery. And I've thought that for a long time. And anterior surgery is appealing in certain ways. You don't do very much bone destruction like you do in the back. You kind of rough everything up in back, but in front you're just taking out the disc and fusing between the vertebral bodies. And that has a real appeal, just sort of aesthetically, as you're doing much less invasive things to the bone. So the problems that they had with, or that we all had with anterior fusions, were the patient didn't like the scar because it went all the way around the chest. Then it became possible to do it with thoracoscopically. So you just had the puncture wound scars, and that's great. But we were having a few too many failures of that, and it was difficult. It was long and hard to get it right. I think my vision for the future would be probably more anterior work, and with more robotics and more controlled robotic kind of things that would make it an easier procedure, and also better ways to assure the fusion of each level when you do it from the front. And I would think in 5 or 10 years, you might move away from some of the posterior surgery and much more toward the anterior surgery. I don't know that, but that would be my guess.
That's interesting, because it also spares levels when you go anteriorly as opposed to posteriorly.
It can, yeah.
Possibly, right? Maybe 1 and 1.5 levels, something like that. And I was speaking to another surgeon, and she was mentioning that she was trained in a lot of anterior work initially, but she was mentioning that over the last 10 to 15 years, anterior approach has kind of fallen out of favor in the US. So it's kind of interesting that you're talking about the
Yeah.
opposite. Yeah, it's
Yeah, exactly. I think you know, if you kind of look back on the history of scoliosis surgery, it's been one of the most changing fields. My very first years in doing it, they weren't putting rods in and were correcting the patients in big casts that they had to wear for 9 months at home in bed. And so you go back to there, the amount of innovation has been fantastic.
And sorry, one final question, because I just keep learning more as I speak to you.
Yeah.
How do you feel about, in the future, vertebral osteotomies in terms of trying to reduce the wedging in a specific vertebra, and of course, mature spines, right?
Well, you know, you get big curves, and you have to do more than just move the vertebra around. You have to restructure them. The most dynamic operation is vertebral column resection, where you're really taking out a whole section of the spine so that you can realign it and put it back together. And it's very difficult, and it's dangerous in terms of spinal cord function, but you're only doing it in patients who have just terrible deformity and sometimes already getting some degree of paralysis and things like that from the deformity. So it's kind of a heroic surgical procedure, but can be very life-changing for the person who needs it.
Absolutely. Okay. Thank you, Dr. Herring. I appreciate your time.
Okay.
Have a great day. Thanks again.
Okay, Take care.